Welcome everybody to the presentation and an introduction to clinical documentation. My name is Pam Fury and I am System Manager of Clinical Documentation for Alameda Health Systems. This presentation will also take you through an overview of the industry requirements for documentation by physicians. Really, the entire role of a clinical documentation department is to bridge the gap between what is clinical language that you all are very accustomed to documenting, and it's very easy for you, as well as the diagnostic language in such a manner that the medical record will reflect the actual diagnosis of a patient. That is the primary role of a clinical documentation specialist in the department. Just to give you a quick example of what the difference is, if you look to the left, you'll see that if you're doing an H&P, you might typically write that a patient has a history of COPD and they're on HOMO2. That's clinical language. But that language that you write according to the great care that you give your patient has not been translated into actually a diagnosis or diagnostic language. The equivalent diagnostic language that needs to be written to reflect what you put in the history is chronic hypoxic respiratory failure. That is a diagnosis, and unless your documentation is written in the form of a diagnosis, it cannot be captured in the medical record and portrayed in the acuity level of the patient. So what is the role of the CDI? The role is to ensure that the acuity of the patient is reflected in the medical record. It also is for the to bridge that gap and be a translator between that clinical narrative that you write to a diagnostic between the physicians and the nurses. You should know that CDI specialists do review your documents real time. So if your patient is admitted on a Monday, your chart will be reviewed on Tuesday, Wednesday, Thursday, every day during the entire inpatient hospital stay. So it's real time, so we can work with the physicians to ensure that they capture the diagnosis early on in the admission of the patient, completely throughout the medical record and the progress notes, and then again on discharge in the discharge summary. A CDI specialist will be sending you queries, which are just written or verbal questions. At Alameda Health Systems, these queries will come in the form of a notice or a letter through Sourian Clinicals at this time. In the future, it will be through Epic. It also helps to protect against auditors. Every patient has a payer, and every payer likes to come in and deny payment or take money back. And it's one of our roles and objectives is to make sure that we have an accurate medical record that has the information and it matches all the charges that are being charged. Therefore, we want to capture the acuity using comorbidities and major comorbidities, diagnostic language as well. The other very important role that we have is we want to ensure that any report card that is published, that the public has access to on demand, to choose who their provider is going to be, both you as a physician as well as a hospital. We want to make sure that we're reflected in the best positive light. I'll just read off to you some of the organizations that are available there for the consumer. Health Grades, CMS Hospital Compare, Leapfrog, Truven, U.S. News and World Report, Joint Commission, Vizient, and the Quality Associations. This is going to look overwhelming. I did provide you with handouts, and this is also on our intranet on the YouTube site where you can also print this. I'm going to take you through this screen, and the next screen I'll just allude to for your reference. These are acronyms, and in your career as a physician you will come across these acronyms being mentioned to you in many different meetings and settings, so I want you to be familiar with what they are. So we'll go through them quickly. ICD-10, that stands for International Classification of Disease. This is not just about coding. This is about clinical evidence for what needs to be documented in the medical record as a diagnosis. So there are 4 major organizations that have come together to make sure and collaborate on what all these ICD-10 codes should be. The American Hospital Association, the Center for Medicaid and Medicare Services, the National Healthcare Statistical Organization, and AHIMA. DRG, you've probably heard of many times. DRG is a diagnostic related group, and what that does is reflect the patient's condition and the resources that are consumed in treating that patient's condition. So a patient may have 2 diagnoses, 4 diagnoses, 10 diagnoses, but at the end of any stay that they have in the acute setting, it gets all rolled up into what's called a diagnostic related group and then presented to the payers. Relative weights correlate to the DRG, and that reflects, it's just a weight, it's a number, and it reflects the patient's acuity that correlates to that DRG and how severely ill the patient is. And acuity is also reflected by SOI-ROM. So a severity of illness, which is SOI, and a risk of mortality, which is the ROM, that's just a higher level of specificity about the severity of the illnesses of the patient. So the more acutely ill the patient has and or the more chronic conditions that a patient has when they present to you, the higher the SOI-ROM scores. And it accurately represents the illnesses and expected outcomes for a patient. It also is very, very important, as we'll talk about later, in any published data for your physician report card and the hospital's report card. A CMI is the case mix index. That is a sort of a predictor of a severity of illness and what the expected reimbursement will be, and it correlates with the average relative weights of the DRG that we talked about earlier. POA is present on admission. It is required that any condition or diagnosis that's documented in the medical record, it's indicated whether or not that was present on admission or not. It is not a good thing if a diagnosis is documented that was not present on admission, because conversely to something being present on admission, when the patient presents to the ED or to the inpatient setting, means that it was then acquired at the hospital. We try to keep a zero defect when it comes to acquiring any healthcare conditions at the hospital. Now that is different than an incidental finding. We just want to make sure nothing is acquired because of a healthcare setting. A CC is a comorbid diagnosis. So those are all additional diagnoses that present in addition to the primary diagnosis. So if a patient is admitted, let's just say for COPD exacerbation, but they also might have some morbid obesity. The morbid obesity is a CC. So you can have many CCs. It just depends on the patient's health status. A major comorbidity is a more severe additional diagnosis that then accompanies the primary diagnosis and the reason for admission. So you could have a patient that comes in with COPD exacerbation. They might have a comorbidity of morbid obesity, but they also might have a major comorbidity of encephalopathy. An HCC is what is called a hierarchical condition category, and that is something that's very important. It's a concept that is a little bit more difficult for people to understand. What it does is it tries to cover and reflect how the severity of illness of all the chronic conditions a patient has across the entire healthcare spectrum, from the physician's office to a clinic, to an outpatient setting, to an acute care setting, to a long-term stay. So it's a grouping and payment model based on I could be admitted with that COPD exacerbation and have no comorbidities, and another patient could be admitted with that same COPD exacerbation in the acute care setting and have perhaps 5 other comorbidities. Well, they are a riskier patient to care for, and they require many more resources. And the idea is to be able to start tracking these HCCs to reflect a patient acuity across the entire healthcare spectrum, not just the inpatient. So it really is the entire disease burden that a patient does present. The next page is, I'm only going to actually talk about one of the items here, which is OM and EM and the OE ratio. So that's an expected mortality and an observed mortality. And all I will say is, if you have a patient that is not very ill and they expire, that does not look good for you, the provider, or for the hospital as the provider. What you want is, as a baseline, that any provider, physician, and or hospital has an expected mortality that equals an observed mortality. Or you would like your observed mortality, how many patients actually pass away, to be less than what you would expect to pass away. So the bottom line is, you do not want healthy patients to be passing away and that be published data to the public, and it all is published data to the public. How do you prevent that from happening? The way you prevent that from happening is making sure that if a patient is going to pass away, that you are reflecting how ill that patient was. How do you reflect how ill they are? Is by capturing all those comorbid and major comorbid conditions of that patient. They came in with COPD exacerbation, they might be morbidly obese, they might have had encephalopathy, they might be a diabetic with complications, they might have some sort of cancer. So if we do not reflect all of the comorbidities with that patient when they get admitted and they expire, it looks as if you as a provider and the hospital as a provider does not have good quality of care. It is very important. There are hospital-acquired conditions that I talked about briefly, like hospital-acquired pneumonia. There are a list of those that we need to try and prevent. We need to try and prevent from a hospital readmission reduction program that a patient that we discharge, like a CHF patient, does not get readmitted within 30 days of the discharge date because the hospital gets penalized. They are just inferring that if a patient gets readmitted within 30 days with any of these 7 conditions that are on this page, that the patient is, that the providers, hospital and physician, did not care for that patient in a quality manner, and so you're penalized because they have to come back and they did not have good discharge instructions and follow-up. What are the gold standards? So I did hand you all a CDI tip sheet that's laminated and quad folded. It's a pocket guide, so please keep it in your pocket with you. And on the first section of that CDI tip sheet are the gold standards. So for a primary diagnosis, when it ends up documenting a primary diagnosis, what you want to determine and ask yourself is, why does that patient require admission to the hospital? That's what that primary diagnosis is to reflect. If a patient comes to an emergency room and they have a laceration, that laceration should be able to be handled in the emergency room, stitched up, and then sent home. If they come in and they have a syncope diagnosis, typically those patients will go into observation to study them for about 24 to 48 hours to determine if there is a finding that requires an inpatient admission. So a primary diagnosis, every patient that comes to an emergency room does not need to be admitted. And that is always reflecting what is the diagnosis that's requiring the inpatient admission. A differential diagnosis. Many times, especially in a teaching facility, physicians write that the patient could possibly have diagnosis 1, diagnosis 2, diagnosis 3, diagnosis 4. However, what's very, very important is that you ask yourself, because it could be all kinds of things, and I'm told by the medical students that they are told to document every possible diagnosis the patient could have. Well, at the end of the day, the medical record is to reflect what the patient likely has, probably has, or is confirmed that they have as a diagnosis. So ask yourself, when you're writing 7 different differentials in the medical record, what am I treating? What am I primarily treating? And that will become your preeminent differential diagnosis. And then you need to commit to a diagnosis. So you might be ruling them out as they go along, but it's okay to write that that's likely an MI or probable or suspected, but you need to make a commitment to a diagnosis throughout the medical record. A sign and a symptom is not a diagnosis, and syncope is probably the largest one that's ever written. Shortness of breath is a sign and symptom. Those aren't diagnoses. Those are signs and symptoms, and your job is to determine what is the condition underlying that's causing the patient to have that sign and symptom. A secondary diagnosis is any diagnosis other than the primary diagnosis. It can be acute, can also be chronic. Those are those CCs, those comorbid, or those MCCs, those major comorbidities that I mentioned. Throughout the medical record, we want you to make sure that your workup is evolving. If it's not evolving, there's no reason for them to be under the care of a physician or even in the hospital. So a patient comes in typically with signs and symptoms and complaints. You do a workup, and then you should be concluding what those diagnoses are, having a treatment, and then being discharged. So it starts with the H&P, ends with the discharge summary. But in the middle of that medical record, it should be saying, oh, this condition was ruled out, this one is ruled in, this is resolving, and this has been resolved. And those diagnoses get carried throughout the entire medical record. And very, very important when you're documenting is the clarity of the severity and the type of each diagnosis. It's very important to write. You cannot just write COPD. You need to write COPD exacerbation if it's acute, or acute exacerbation of COPD, or indicate if it's chronic. It makes a big difference in terms of the length of stay of a patient and what you're actually treating, if it's an acute or chronic condition. And then if there is a type, and congestive heart failure is the easiest, we need to know, is it systolic or diastolic? So clarification of severity and type is very important. Why is capturing the acuity of the patient important? So when we capture all of the comorbid conditions that a patient has, like that obesity or the diabetes or the cancer, that improves the overall picture. The clinical picture of the patient truly reflects the severity of the illness of the patient and the quality of care that you are providing. So if you look down here, it captures the severity of illness. It also captures that risk of mortality. It also allows us to have increased resources for the care. So if a patient has malnutrition or they're obese and we need to bring in a registered dietitian to see the patient, that's a resource. If we don't capture that obesity or that malnutrition and the severity of that, we'll never have the resources to care for them. It also increases the ability for a longer allowed length of stay. That doesn't mean we're going to make the patient stay longer in the hospital, but what it does mean is that it gives us more allowable days from a payer perspective for you to care for this patient and tend to them. And we want to increase the allowed length of stay based on a patient acuity. And then it also increases the payment for the care that you are providing and the resources that are being utilized by the hospital. The other reason capturing the acuity of the patient is important is because it does align that expected mortality with the mortality that we actually observe. And that expected mortality is compared against cohort hospitals, and it's done nationally and regionally. So in certain different geographic areas, maybe the expected mortality is higher. But in all situations, you want your observed mortality, how many patients are passing away, to be less than the expected mortality geographically or based on your patient group. All of that, again, all of this acuity of this patient, your care and your quality outcomes are published to the on demand by the consumer and all of those organizations I mentioned earlier, and they're all given star ratings. 5 is the highest star rating and 1 is the lowest. So you are the author of your patient story. What's very, very important here is to know that your publication of your patient story, which is your medical record, every single one that you write and every single book that you author is being reviewed by many different individuals and many different parties. So just know that you are the author of the patient story. And it has many parts. It has a beginning, a middle, and an end. And like I mentioned earlier, in the beginning you start with an H&P. And in the end, you conclude on what this patient's actual acute and chronic conditions and diagnosis were in the medical record. I'm going to run through this briefly and take you through this patient's case scenario so you can see the difference between the beginning, the middle, and the end. So your patient comes in, it's a 66-year-old female with a history of CHF, CAD, hypertension, COPD, on HOMO-2 at 2 liters, CHF with an EF of 20 to 25%, PVD, seizure disorder, CVA with dysphagia. What does the patient present with? The chief complaint is shortness of breath. They come to the emergency room with shortness of breath. So you now have a differential diagnosis of many different things. It could be COPD exacerbation, it could be heart failure, it could be respiratory distress, it could be pneumonia, it could be CHF. And you're documenting that as your differential diagnosis. So as you start to do all your diagnostics, your findings are the EKG is normal sinus rhythm, the chest x-ray has opacities, the ABGs, the PO2 is 56, PCO2 48, pH is 7.25, room air PO2 of 85%, respiratory rate of 26. On physical exam, the patient is using their accessory muscles to breathe and they have shortness of breath with distress. That's within 24 hours of the patient coming into the hospital. Then what you start to see, okay, so we're going to go through 3 or 4 days of the patient being in the hospital. On the first day, actually probably day number 2, on June 5th, you, after doing your diagnostics, you see that the BNP is within normal limits. You document there's no bronchi or rales on chest auscultation, there's no edema or JBD distension noted on the physical exam. What you want to write here, based on this, is that it is less likely decompensated heart failure, right? Because you can see all your diagnostics, your BNP, the chest auscultation, no edema, no JBD. So you have it's less likely decompensated heart failure, but you suspect aspiration pneumonia. Why would you suspect aspiration pneumonia? You go back and you look at the patient's history. They have a CVA with dysphagia. Shortness of breath can be caused by any one of these things in the past medical history. And our goal at this acute hospitalization is to figure out what it is at this moment is causing this symptom. So you can suspect that it's aspiration pneumonia. It's less likely decompensated heart failure. And you also note that the patient is remaining on BiPAP. In our evolution of our progress note on 6/6, you order a speech eval and a video fluoroscopy, and those results come back positive for aspiration. So you repeat a chest x-ray, which shows infiltrates in the left lower lobe. Chest auscultation is clear of wheezing. ABGs are improving. You're going to continue the antibiotics as your treatment. Now what is your differential diagnosis? Now you're beginning to solidify and make a commitment to your differential diagnosis. Aspiration pneumonia. It's not likely, it's not suspected, it is aspiration pneumonia. Respiratory failure, and COPD has been ruled out. That's your new differential diagnosis, so it's evolving. The next day, you're going to write them as an actual problem list, and you need to address each individual diagnosis as a different problem. So on the third or fourth day, you have your number one problem is aspiration pneumonia. You write your plan, you're continuing antibiotics using thickened liquids. You're going to repeat your chest x-ray and repeat a swallow eval. Your second problem on the problem list is acute on chronic hypoxic respiratory failure. Your plan is to wean off the BiPAP and maintain oxygen sats over 93% and repeat ABGs. Why is it acute on chronic hypoxic respiratory failure? Well, on June 6th, when you just wrote a diagnosis of respiratory failure, that was not accurate and detailed enough. We needed to know, is it acute respiratory failure, severity, or is it chronic respiratory failure? Or is it both? And in this case, it's both. Why is it both? Well, your patient's still on BiPAP. They had all of the signs and symptoms and clinical evidence of the acute respiratory failure, but they also have a history of being on HOMO2 that is continuous, so you have acute on chronic, and in this case it is hypoxic respiratory failure. Patient's going to be discharged. You're going to conclude in your discharge summary. So in the end, your inpatient diagnosis are acute on chronic hypoxic respiratory failure, aspiration pneumonia, most likely secondary to a CVA, and the patient also has a history of chronic systolic heart failure. That's a perfect illustration of the beginning, middle, and the end of the patient care that you'll be providing. So I'm going to take you just through some actual case studies so that you can see. So an MS-DRG, the diagnostic related group, has different severity levels. So it will be an MS-DRG with a comorbidity or also with a major comorbidity. These are just very quick examples of why the words matter. So on the first column, you're going to see symptoms or diagnosis that you can write that will have no impact on the acuity or severity of measuring how ill that patient is in the medical record. And then the middle column will show you what is a comorbidity, which illustrates really a slightly more detailed level of the diagnosis. And then the diagnosis in the third column is high impact. So these are all related diagnoses. And what you want is to capture the most severe state of the diagnosis. So no impact, anemia, low impact acute blood loss anemia, high impact would be hemorrhagic shock. No impact, hypertension. Low impact, hypertensive urgency or crisis. A high impact is hypertensive encephalopathy. No impact at all in the acuity is altered mental status. Low impact is dementia with behavioral disturbance, or a higher impact is metabolic encephalopathy. No impact on acuity is chest pain. A low impact on acuity would be demand ischemia. Much higher impact on acuity is acute MI. No impact is riding weight loss. Some impact is writing moderate malnutrition. A high impact is writing severe malnutrition. No impact on acuity is just writing CHF. But some impact is writing chronic diastolic CHF. A high impact is having acute diastolic CHF. No impact is if you write renal insufficiency. A low impact or some impact is if the patient has AKI. And a higher impact is if the patient has ATN or acute tubular necrosis. So really what I'm trying to illustrate here is everything in the first column is really what you need to specify in your documentation to a higher degree of acuity and specificity. So that's a lot of diagnosis, but it just gives you some idea of what should not be written and how you need to have more specificity to capture that in a patient. And now let me show you what this translates to when the medical record gets reviewed and sent to payers. So if you have an MSDRG, a patient comes into the hospital without any comorbidities at all, and you document weight loss, and let's say that they had a major bowel procedure. So if they had a major bowel procedure and there were no comorbidities at all, they just come in, it would just code to what's called a diagnostic related group of 331. So if you look down under the first green arrow, that gives us that relative weight of 1.66. It also gives us the severity of illness and risk of mortality of 1/1, so the patient then can stay for a length of stay of 5.2 days, and the hospital would get reimbursed $8,923. However, if you were to have written, instead of weight loss, if you would have written mild malnutrition, the DRG would have a comorbidity. So they come in for the exact same procedure for the for the major bowel procedure, but they do have a comorbidity of malnutrition. So it shifts that DRG category from 331 to 330. Follow under the second green arrow, so that same patient now has a relative weight of 2.5 instead of 1.6. They have a severity of illness and risk of mortality of 2 and 2. Now the patient can stay 8.3 days instead of 5 days. We've then just authorized this payment, staying in for further treatment for 3 additional days, and the reimbursement to cover the resources for that additional treatment is $14,000. Now let's say that that patient's BMI was 17.9. They came in for the same major bowel procedure. Well, that is a major comorbidity because that's considered severe malnutrition if it meets all the other clinical evidence. So now that DRG category shifts from 331 to 329, so it is that DRG with a major comorbidity. Same exact bowel procedure, same exact patient, but just with the proper documentation. So now the relative weight, which is the acuity of that patient, is 5 instead of 1.6. Now that severity of illness and risk of mortality is 3/4. Now the highest acuity level you can get is 4/4. Now that length of stay has increased from 5 days to 12.8 days to 13 days. So what is it? 8 additional more days to care for that patient. And then the reimbursement is $28,400 instead of $8,900, which is almost $20,000 more to cover the resources required to care for that patient. That is how important capturing the accurate acuity of a patient and the diagnosis is on each and every patient that you see. This is just the bowel procedure with the MCC. It shows you the same thing I went over. And this is just another case study, and these are real cases that we've had. This is a craniotomy. So a patient comes in with a craniotomy, and initially the weight is with no comorbidities or major comorbidities, and the weight is a 2.2. Their severity of illness is 2/2. Their length of stay is 3 days with a reimbursement of $9,600. If we capture a major comorbidity with this MCC, instead of it being weight loss and it's severe malnutrition, it increases the acuity weight of that patient from a 2.2 to a 4.3. Their severity of illness goes to 4/4. Their length of stay goes up to 9.7 days from 3 days. So we get an additional 6 days, and their reimbursement goes from $9,600 up to $16,000. So what's important here, if this patient with the craniotomy was to expire, but we didn't have that severe malnutrition captured, it would look like a patient that wasn't that ill. Their severity of illness was only a score of a 2/4. The risk of mortality was only a 2/4. That would not look good for the quality of care being rendered. by the physician or the hospital. Now, if a patient that had a severity of illness and a risk of mortality of 4/4, because we're truly reflecting that medical record, it's reasonable to expect that somebody with that risk of mortality and severity of illness might expire. On this page right here. And then what I do want to say, we are partners in the care for our patient and the delivery of the quality care. So we are not Jason. We are very friendly and partners in the care and play nice in the sandbox. And we are here for you and hope that you will contact us. All of our contact information is on the back of the tip sheet that we provided, and really look forward to working with you to optimize your medical record for your patient. Thank you very much.